Okay, good to see you everyone again. And this class we will focus on the supraventricular arrhythmia. Do you remember that at the last class we just talked about the sinus arrhythmia, right? Including sinus tachycardia, sinus bradycardia, sinus arrest, and importantly, sick sinus syndrome. So I think that during the study of this arrhythmia, hopefully you can master the way of study of ECG. And for these lessons, uh, we also focus another important arrhythmia, that is the supraventricular arrhythmia. Firstly, we will study the premature atrial contraction, or usually called PAC. A PAC usually occur when atopic focus in the atrial fire, like a trigger activity. Remember that three mechanism of arrhythmia, right? Accelerated automaticity, trigger activity, re-entry circuit, right? Okay, and the PAC has had a relationship with trigger activity. Yes, has ectopic focus in the atrial fires, and usually occurs before the next sinus nodes in pass or a re-entry circuit is established. This is the ECG of a PAC. What we can see is that there is a P wave here, and it's a QS complex after the P wave, right? And the next, we see another different P wave here. The morphology of the P wave is slightly different from this one. Can see that? Yes. This P wave is it's a little bit bigger than this one, right? Yes, it's a sinus P wave, and this P wave is not a sinus one because the morphology is different. Although the direction of the P wave is the same, but the shape is a little bit different. You get that? Yes, it's smaller, right? It looks smaller. And this one, the third P wave, is the same as the first one. So this P wave is from sinus node, and this P wave is also from sinus node. But this P wave and this P wave, they are slightly different from the sinus P wave. So obviously the P wave is not from the sinus node. Where does it come from? Yes, it's from the atrium. It's from the maybe the left atrium or the right atrium, but not from the sinus node. Right, and the time of the P wave is a little bit earlier, right? For example, now you can see it's a P wave here, right? Sinus P wave here, the sinus P wave here, sinus P wave here, sinus P wave here. So the duration of the PP interval, you see that? What is the PP interval? The interval from this P wave to this P wave, right? This is the interval, and this is the second interval. The interval of the P wave is regular. You see that? Yes, is the interval is this one, and the second interval is the same. The third interval is the same. So it's a regular P wave interval. But what about the PAC? It's a PAC, right? It's a contraction, a premature contraction from the atrium. So the PP interval, you see that the PP interval is different, is earlier, right? So the PAC usually comes earlier than the sinus node. You get that? And the characteristic of the PAC is a premature P. The premature P is different from the sinus P. Here we just explained it, right? And the PR interval usually longer than 0.12 seconds. It's a P wave here, it's a QS complex here. The PR interval usually longer than 0.12 seconds. And the QS complex is the same as sinus beat. This is a QS complex. They are narrow QS complex, right? This QS complex comes from the PAC, and this QS complex comes from the sinus P. But the QS complex is almost the same. Why? Because the electrical activities, no matter it's from the sinus node or it's from the atrium, they are all transmitted to the left bundle branch or to the right bundle branch together. So the P wave, the QS complex from the sinus P and the QS complex from the PAC are almost the same. Okay. And premature P occurring very early in diastolic may be followed by either apparently conducted QS or no QS, and sometimes there is no QS followed by the premature P. Okay, what is the reasons of the PAC? There are many causes of PAC, like infection, myocardial ischemia, psychological stress, and tobacco, alcohol use, caffeine injection, or something. And many heart disease can also cause PAC. And sometimes the anti-arrhythmia drugs can also cause PAC. Right? And sometimes in normal heart, it usually has a PAC, but the total number of the PAC is not too much. Okay, what should we do for the PAC? The atrial premature beats do not require therapy most of the time, right? And most of the time, the PAC does not necessary to be treated unless they produce symptoms of tachyarrhythmia. And sometimes we should manage the factors inducing the PAC first, like infections, like myocardial infarctions, like psychological matters or something. And usually we use the beta blockers or verapamil, right, the CCB, to treat the PAC. Okay, next we will study the PSVT, that is the paroxysmal supraventricular tachycardia. Okay, symptom. The patients with the PSVT usually has palpitation, chest discomfort, and even angina pectoris. Sometimes it has a syncope, and it can induce heart failure or shock. And the palpitation of the PSVT begin and end abruptly, and sometimes it lasts a few seconds to several hours, and the symptoms vary according to the heart rate. I mean that if the heart rate is higher than 180 beats per minute, maybe it can cause a syncope. But if the heart rate is less than 160 beats per minute, sometimes it just only called palpitation or something, right? So the symptoms vary according to the heart rate. The type of the heart disease, for example, the patient with or without the structural heart disease is different if the patient has the PSVT. So the characteristic of the PSVT is that the heart rate is up to 150 to 250 beats per minute, and the QRS compress is regular. Remember, absolutely regular, right? And the QRS compress is narrow. It's also narrow, and sometimes it is not so absolutely right. Sometimes it has a bundle branch block, so the QRS compress can be a wide QRS compress or something. But the RR interval, the heart rate should be, the heart rhythm should be absolutely regular. And the P wave differs from the sinus beat. Okay. Let us see this ECG PSVT. What we can see here is a P wave, right? Sinus P wave, and it's a QRS complex. Yeah, it's a normal heartbeat, right? Normal heartbeat. And what happens? Yeah. For this ECG, you can see there is no sinus P wave, right? The sinus P wave is disappear. And there are so many, it's a very fast heart rate replace the normal heart rate, right? You can see the R interval, the QRS compress here, the RR interval. Yes, it's faster than the normal one, but they are regular, right? Absolutely regular, and no sinus P wave can be seen here. So the diagnosis should be PSVT. And this ECG, we can see is atrial tachycardia. This somebody would say that this P wave come from the sinus node, right? Yes, of course. It's possible that this tachycardia is from the sinus node. We can call it a sinus tachycardia. But we should compare the sinus P wave and the atrial wave. If the morphology of the P wave is different, from the sinus P wave, then we can say this tachycardia is not from the sinus node. It should come from another place like PAC or something, right? So this tachycardia is likely from the atrial structures, from the atrial tachycardia. And we notice that the heart rate of this ECG is 150 to 250 beats per minute. And the sinus tachycardia, the heart rate of the sinus tachycardia is rarely up to such fast, okay? And this one, what we can see here is tachycardia, right? With a narrow QRS complex. What about the P wave? Does it sinus P wave or not? Of course, there is no sinus P wave here, right? So this ECG is not the sinus arrhythmia, right? It should be others. Okay, what about the RR interval? Is regular or irregular? Okay, the RR interval here is absolutely regular, right? This one. they are absolutely regular, without any sinus P wave, and with a narrow QRS complex. And the heart rate of this ECG maybe is up to 180 beats per minute. So the diagnosis of ECG should be PSVT, right? PSVT. So actually, it's an AV node reentry tachycardia. There is a reentry activities at the AV node that can produce such tachycardia. Okay, this one. The heart rate is very fast, right? It's a tachycardia. So where does this tachycardia come from? From the sinus node or other place? Firstly, we should find is there any sinus P wave here at the front of the QS complex? Okay, there is a small P wave here, right? You can see it's a small P wave here, but most importantly, this P wave is not at the front of the QS complex, but at the end of the QS complex. You see that? This is a QS complex, right? This is a P wave here. It's at the end of the QS complex. And also this one. A P wave is follow the end of the QS complex. So it's not a sinus P wave. This P wave comes from another place, but from the sinus node. So this is not a sinus tachycardia, right? And the rhythm is absolutely regular. Yes, it's absolutely regular. And the heart rate is up to 200 beats per minute. So the diagnosis should be yes, PSVT. Actually, it's a AV reentry tachycardia. So somebody would ask, how does the P wave, the P wave emerge? Where does it come from? I say that the P wave is not from the sinus node, right? Actually, the P wave is from a reentry P wave. It's a retrograde P wave. That means a P wave that go back from the ventricle, because it has a reentry, right? The activities from the atrial to the ventricle through the AV node, and then it goes back to the accessory pathway through the accessory pathway. So it produces a retrograde P wave here, but not a sinus P wave. Yes, so it's a typical AV reentry tachycardia. So the treatment of the PSVT is also important. Vagal maneuvers. What do you mean about the vagal maneuvers? Carotid sinus massage is most usually ways, and also Valsalva maneuvers. Here we do the carotid sinus is a carotid sinus massage, right? Only one side of the carotid massage should be used. We cannot massage both two sides of the carotid path. Otherwise, it would produce a very slow heart rate, and it can produce syncope. And this is the picture of the Valsalva maneuvers. We do the Valsalva maneuvers to terminate the PSVT effectively. Yes. Okay. The treatment of the PSVT also include the pharmacological interventions. Yes. Verapamil, ATP, propafenone. Yes. The three most used, three common pharmacological intervention. Okay. Sometimes you should use the electrical cardioversion for patients who has a hemodynamic unstable conditions. Like if the blood pressure is lower, is smaller than 90 or 60 millimeters of mercury, the patient usually have obvious syncope. So we should do the electrical cardioversion immediately, right, to restore the sinus rhythm. And we can use the transesophageal atrial pacings. We can, and most importantly, right, if we want to cure this PSVT, the radio frequency ablation is the most effective way, and is also the only way to cure the PSVT. Okay, the third one is atrial flutter and atrial fibrillation. The etiology: pneumatic heart disease, cardiomyopathy, hypertension, mitral valve prolapse, or infection or something. And sometimes it has no apparent cardiac disease, so we call it the idiopathic atrial fibrillation or atrial flutter. The symptoms of the atrial flutter and atrial fibrillation is also important, including the paroxysmal or persistent palpitation and chest comfort. The cardiac output decreased by more than 25%, and also increased the risk of thrombus formation. We usually call it as the systematic embolic. So the physical examination, including the ventricular beat, very peripheral pulse, and absolutely irregular heart rate. Remember that, absolutely irregular. We just mentioned the PSVT has a absolutely regular, right? And the atrial fibrillation is absolutely irregular. Yes, very important. Absolutely irregular. And the variations of in the intensity of the first heart song. Okay, the characteristic of the ECG of Fllutter: it has a regular big F wave, big F, right? And the rate of the F wave usually up to 250 to 350 bit per minute. Yeah, very important. You must remember this number: 250 to 350 bit per minute. And the ventricular response to atrial flutter may be irregular, or sometimes is regular. Okay, let's see some ECG here. What we can see here, it has yes. Can we see a sinus P wave here? Obviously, there is no sinus P wave, right? So this ECG is not a sinus arrhythmia, right? And we can see the R interval is regular. Yes, of course, it's regular. It's a narrow one, okay? But is it a PSVT? Maybe it's a PSVT, right? But what is most important is that this wave, it has a very big F wave here. Very big F wave, right? It's a big F wave. So the PSVT does not have a F wave. If you can see a big F wave in an ECG, you should diagnose atrial flutter. Yeah, no matter the heart rate is regular or irregular. Okay, the big F wave is the characteristic of the atrial flutter. Okay, and the characteristic of the atrial fibrillation, usually P wave disappear, and a small irregular small F wave replace the sinus P wave, right? And pay attention to the rhythm, to the rate of the small F wave. The rate of the small F wave is up to 350 to 600 beat per minute. Remember this number, 350 to 600 beat per minute is very, very important. That means the rate of the F wave is very, very fast. Okay, the QS complex is irregular, right? The rhythm of the QS complex is absolutely irregular, right? Remember that, absolutely irregular. And it usually has a narrow QS complex unless the intraventricular block has occurred. Okay, let's see some ECG here. It's a V1, right? V3, V5, something. Okay, what we can see here, there is no sinus P wave here, right? It's not from the sinus node. Is it a PSVT? We can see here the rhythm of the QS complex. The PSVT should be absolutely regular, right? But for this ECG, the rhythm of the QS complex is absolutely irregular, right? So it's not a PSVT, and it's not a sinus rhythm. Sinus tachycardia is not a sinus tachycardia, right? So is a big F wave here? No, it's a small F wave, very small F wave, right? And the QS complex is absolutely irregular. So the diagnosis should be atrial flutter or atrial fibrillation. Yes, the diagnosis should be atrial fibrillation. Okay. So the management of the atrial fibrillation is important, depending on the ventricular rate and the status of the left ventricular function. For example, if the patient has unstable hemodynamic conditions and a cardio version, electrical version should be used first, right? Electrical cardioversion should be first, and some drugs can terminate the atrial fibrillation. Digoxin, verapamil, propafenone, amiodarone, and verapamil and digoxin usually can slow down the rate of the atrial fibrillation, and propafenone and amiodarone can terminate the atrial fibrillation. Okay, sometimes the atrial fibrillation persists for a very long time, so we call it a chronic atrial fibrillation. So the treatment of the chronic atrial fibrillation is a little bit different from the paroxysmal atrial fibrillation. It only has a rate control because it's very, very hard for us to terminate the atrial fibrillation. Sometimes you can use the catheter ablation or electrical cardioversion to terminate the atrial fibrillation, but just for a little while, right? Maybe 1 month or 6 months or 1 year. Some atrial fibrillation would come out again. So it's a little bit difficult for us to cure the chronic atrial fibrillation. And for atrial fibrillation, we should pay attention to another therapy. That is the anti-thrombotic therapy. We use the warfarin for the anti-thrombotic therapy. Okay, this is the cardioversion machine, right? What we can see here, we can detect the arrhythmia like atrial fibrillation, and we deliver a cardioversion shock. Yeah, here or here. is the red arrow here, right? We deliver a shock here, then we can terminate the atrial fibrillation, and a sinus rhythm come out again to get this P wave, right? There's a sinus P wave, right? Sinus P wave. So before the deliver of the shock, there is no P wave here, right? And after the shock deliver, the P wave, the sinus P wave come out again. Okay. And this is the picture of the interventional therapy. It's the catheter therapy where we do the catheter ablation. We eliminate some disturbed electrical activities at the left ventricle. Yes, it's a pulmonary wave here, and we segmented this electrical, and sometimes it can terminate the atrial fibrillation. And we also can use the cryoablation, right? The cryoablation, the cold balloon, to terminate the electrical activities at the left ventricle, and also an effective way to stop the atrial fibrillation. Okay. In this lesson, we have talked about the supraventricular arrhythmia, including atrial premature beat, PSVT, right, paroxysmal supraventricular tachycardia, and most importantly, atrial flutter and atrial fibrillation. So I need you to memorize the characteristic of the atrial flutter and the characteristic of the atrial fibrillation, especially the heart rate of the F wave, the flutter wave, and the fibrillation wave, right? And what about the characteristic of the ECG of atrial flutter and atrial fibrillation? Okay, and finally, what is the effective way to terminate the atrial flutter and the atrial fibrillation? And also the treatment therapy for the PSVT is also important. Okay, see you next time.